you for coming on a Saturday for the first Shock Symposium here. Before we start, I would like to thank all the people that help us organize this symposium. First, a big thank you to Stacy King, our CME coordinator. Thank you to the office staff, Dr. Shakur's office and my office, helping us set up this conference. This is all kind of mom and pop shop. We started from a small idea and it kept growing to a bigger event for a 2-day event. So everything that you see, it's just myself, Dr. Shakur, Stacy, and the staff in our office that we try to organize this symposium. We hope we're gonna do a good job. We hope we didn't miss anything. We're open for any comments in order to improve things for future events. Some housekeeping first before we start. So obviously this is the conference room, the moderator table. The registration is there is a QR code for registration, and after that there is another QR code for evaluation, so you can get your CME. The exhibitors are next door. You can exit here and go to the next door. The exhibitors are in the next room next to us, and there is a breakfast back there. There will be lunch also served in the next room. Coffee, water, and the drinks are on this side. Dr. Bees was supposed to give us the introductory remarks, but he's sick, so he couldn't come. So I'm gonna introduce Dr. Shakur. He's the director of our education program, and he plays a big role in setting up all those conferences for the physician and the nurses. So without further ado, Dr. Shakur.
Well, thank you, George. Well, again, thank you very much for coming over on a Saturday morning. And like George has mentioned, this is our own effort by few crazy people who felt and deeply believed in education for shock. And as you know, whenever you talk about shock, they say, how do you treat shock? They say, well, it depends. So that depend part, we want to take it away, and we want to form some standardized approaches so which can be used each time, and we learn from there. Right, that's true. Well, absolutely. So we're going to have a series of speakers, and the program has been carefully drafted, starting from the diagnosis, hemodynamics, and then all the other nuances, and then local issues which we have. As you know, this whole team depends on the nursing care, starting from the ICU, and then surgeons. So it's a big collaboration. Those days are gone that everybody worked in silos. We all work together and try to bring the best for our patients. And so I hope you get something out of it, and then we can use it in our practices and for our patients. Everything is about patient, and this whole education is basically to have better outcomes, and our patient gets the benefit of all the new technologies and new ways of treating. I will we'll start this program, and our first speaker is Dr. Kalia.
Hi, thank you. Our first speaker is Dr. Kalia. He's the director of the cardiac rehab and the heart transplant at Banner University. He's an associate professor at the University of Arizona and Creighton University. Thank you, Dr. Kalia, for coming.
Hello? Hello? Can you hear me okay? Hello? Will it increase the volume? Hello? 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 Morning, everybody. Can you hear me okay?
Who's the other one?
Hello. Hello. Better? Hello. Hello.
Hello, better? Okay. Good morning, everybody. So hopefully, once again, I want to thank the organizers, Dr. Shakur, Dr. Nseir, and all the other staff to give me an opportunity to actually speak today. Well, I don't want to shock you early in the morning, so hopefully, even if I do, hopefully you'll recover by the end of the talk, right? Okay. So I think this is an important topic. This is something that's so difficult to manage. And not only these patients are so sick, but it's just not one person that's going to take care of it. It's the entire staff, nursing staff, several other caregivers, surgeons, cardiologists, who have to come together to really take care of this patient. Otherwise, the mortality remains exceedingly high. And hence, this is an important topic to discuss further. I know we have a great series of lectures today, so we'll start off with just a definition. I don't know if there's a lot of echo. If you could, you okay with that? Let's note. I can do this. So the objectives is just to see what the spectrum of cardiogenic shock is and what does it really involve. And if you look at this, if you look at the spectrum from what end, how do we actually see where it starts and where it ends and what we could do in between to move this back and forth. And how do we diagnose cardiogenic shock? And what are some of the trends that you see, especially in acute MI? We have a lot of interventional cardiologists who see a lot of these, majority of the cardiogenic shock patients who come in with STEMI or acute or ACS. What are some of the prognostic models? Can we look at some of the early identifiers you could see and say, oh, this patient might be doing worse. You want to act now. And what's some of the underlying pathophysiology? That's going to be important for you to say, how do we act on this patient? Is this what's revved up? How can we sort of degrade some of the activation of some of the pathways? Can we do that? And of course, the medical management, and we have a lot of surgical interventional and mechanical circulatory support management that we're going to hear today. So let's talk about a gap question. So 68-year-old male who present to the emergency room, you see this all the time, dyspnea, chest pain, blood pressure 70 over 40, and you diagnose an anterolateral ST segment elevation MI, right? So all of the following are true regarding cardiogenic shock, except there's one that's not accurate. CS, which is cardiogenic shock in STEMI, is associated with high mortality. Institution of early PCI in STEMI with CS has improved survival. Early institution of inotropes and mechanical support in cardiogenic shock has not improved outcomes. In STEMI and cardiogenic shock, early PCI versus CABG carries no survival advantage at 1 year. Non-STEMI, or any heart failure with cardiogenic shock, associated with cardiogenic shock, carries better prognosis than STEMI associated with cardiogenic shock. So think about these things. We'll come back to it later, right? Okay. Definition. So it's a syndrome, so it's not really one particular thing. My blood pressure is low. Is that cardiogenic shock? So it's really not just one aspect of it. There's a gamut of findings that you really have to identify in these patients. Sustained. So the final issue is going to be sustained tissue hyperperfusion and end organ damage. Once you see this, you know that's a problem. And there's, of course, very high mortality within the hospital. And primary cardiac disorder with low cardiac output. It's not just something that comes in with sepsis, et cetera, even though that's considered shock, but it's truly not cardiogenic shock. Eventually, even sepsis may draw the heart into it, may eventually lead to cardiogenic shock in association with it, but the primary event might be different. So why is it so difficult to take care of these patients? As you can see, the definitions of cardiogenic shock keep varying. So, a lot of times you see majority of these trials, European Society of Cardiology shock, IABP shock to culprit shock, all of these have used, majority of the times is going to be systolic blood pressure less than 90. So that's one of the primary things if you can take home as one of the identifying features. If you start seeing low blood pressure, other than, we take them to the cath lab, do the stent, don't walk away. It's so important that you closely follow these patients. And then the other thing that's going to come into play is going to be altered end organ perfusion. So you start seeing renal dysfunction. The urine output slowly decreases. So those are important early identifiers for you to say, what do I do now? So other than just giving diuretics, et cetera, you really have to look further into carefully with these patients. Then if you have a right heart catheterization, then you look at some of the hemodynamic data. I think we're going to have a talk on the right heart cath and hemodynamic data. So which is going to be the index if you have, even on top of having an inotropic support, if it's less than 2.2, urine output we talked about. And of course, there's other things in the laboratory that you can see, which is elevated lactate. You can see some of these trials, they utilize different criteria to diagnose cardiogenic shock. Hence, it makes it sort of hard for you to give a streamlined recommendation as to say, oh, you find this, you have to do this. So there's nothing like that if you want to base yourself on some of the trials that's been done in cardiogenic shock. So the initial insulting agent is always going to be myocardial dysfunction. It could be an acute MI, it could be acute on chronic heart failure comes in with no underlying coronary artery disease. And that in turn is going to increase your wall stress, pulmonary congestion. So this is what you grossly see in a lot of these patients. And then, boy, this kicks in. So this is going to be the hardest thing for you to really know. Once you have the sympathetic activation, your cytokine release, nitric oxide synthase, catecholamine, CNS-alpha, it's all this interleukin reactive oxygen species. Once this sets into motion, no matter what, you can open up the artery, you can give them 7 liters of flow, you can do anything you want. It's so hard to get these patients out of this. You know your blood flow is good, you know your cardiac index is better. Despite that, once you set this set of things in motion, it becomes very hard to take care of those patients. And this in turn is going to relate to every cell in the body is going to start suffering with hypoxia, acid-base disturbance, et cetera, which would really cascades into really high mortality that you see in patients. So, we're sort of still stuck in the milieu of looking at, okay, the patient has low cardiac output. The index is 1.8. Well, add dobutamine, add milrinone, add this. Okay, let's put an Impella in. Let's put a balloon pump in. So we're still stuck in this situation. So how do we when the patient actually gets into this sort of a cycle which propagates the starting event here, the insulting event here, propagates into all this cytokine and all this milieu changes, which further leads to malperfusion, multi-organ failure, and death. So how do we stop these wheels from propagating into this situation is the biggest challenge. So I think we have to seriously look at what can we do once this sets into action. How do we get back the patient into a better situation of tissue perfusion? That's going to be the toughest one to do. So obviously the best thing for you to do is if you can prevent these wheels to turn in the wrong direction. If you can try and prevent that and see if you can take care of some of these patients early on, I think that might be the magic bullet, at least at this time. So hopefully we'll have more trials looking at once this is already onset, how do we reverse those patients? So that's something that we have to look into. I'm sure there's several trials looking at that. So the other thing that would be interesting is, there's always a situation where it's called pre-cardiogenic shock. There's always a patient out there, right? He comes in, he has an acute MI, you put in a stent. Yeah, the urine output is 30 cc's an hour. Yeah, he's okay. What's his blood pressure? Sometimes you don't even have an arterial A line, right? So you have a cuff pressure. They're looking at, they're very happy because it's 120 over 60. Oh yeah, he's okay. We'll see, we'll have it. But this is minutes to hours, you start cascading these patients down. So this is where you have to be careful. Once he gets into this classic cardiogenic shock and then gets into refractory cardiogenic shock, no matter. That's when all the alarms and bells goes off. It might be too late for you to get him back there. So if you can sort of get the patient here in pre-cardiogenic shock, identify those important features right then and there and see if you can reverse it. That's the best way that you can get these patients out of shock. And what are some of the features that you can identify with pre-cardiogenic shock, right? First thing is hypoperfusion. It's always about renal. So always watch those kidneys so carefully because we miss that. We wait until the creatinine goes up to 2, 2.2, 2.3, maybe already down there. So you have to be careful. And how often are you happy with this, blood pressure, cold extremities? Be surprised how often we don't touch the feet, we don't touch the hands of these patients. We're happy with just the numbers, Swan-Ganz catheter and blood pressure cuffs. Really, I think the examination is still a critical piece that we miss. And Dr. Deeb was just saying how the nurses are so important in caring for this patient. I just overheard him say, he says, yeah, we just go in there, we spend about 2 minutes, and how's the patient doing? Walk to the next patient room. So the nurses are there day in and day out. So it's critical for you to engage the nurses who are so good. I mean, let me tell you, if they tell me that there's a patient is not doing well, the patient is really not doing well. So you really need to pay attention to that. So I think the nursing staff becomes critical in identifying some of these patients. Altered mental status. Yeah, he's just a little tired. So, plus he comes off from the cath lab, so he's on sedation, right? That's another thing. You don't know if the mental status is because of low cardiac output or he's truly having a sedation-related problem. So something to keep in mind. And of course, don't let the blood pressure dwindle down too low. So in the pre-shock, usually the blood pressure stays okay. But once you start seeing some other features, just act on it if you can. So hypoperfusion, this is a classic cardiogenic shock. Blood pressure falls. Then you start looking at, what do? I add inotropes. The cardiac index, if you have a right heart catheterization, is getting low, and your filling pressure starts going up. And of course, the urine output continues to dwindle. And then with the refractory form, then the tissue perfusion sets in, your organs are failing, your transaminases are higher, total bilirubin is higher, your renal function is worse, there's no urine output. You bombard them with 80 milligrams 4 times a day, 160 milligrams of Lasix, nothing happens. So that becomes a tough situation. So you just have to keep thinking about, how do I really sort of go back and forth? How do I identify early on? And then, is there anything that I can do to get him, if he's in shock, get back to a pre-shock situation? You can stop me anytime. You guys are okay? You guys are all awake? Okay, good. Yes, sir. Yeah. Not particularly. I mean, they have smaller observational studies that look at it. But once again, it's going to be a clinical acuity. So if somebody comes in with a massive, large acute anterior MI, large area of jeopardized myocardium, the likelihood of that patient getting into shock is very high. So I think it's going to be preclinical situation that would really dictate what you have to look for. Some of the things that they've looked at, you can look at cardiac power output. We'll talk about that a little bit if you know for sure. And then some of the other things that you look at, biventricular failure or higher risk of having. So somebody who already has a prior MI, EF of 25%, comes in with another MI. Those patients going into shock are exceedingly high. So I think it's a preclinical determinants that would actually dictate what you want. And then you can start looking at lactate and other the tissue perfusion measures. But for trials per se, looking at just the preclinical state to say, this is the patient absolutely is going to go into CS are limited. Yeah. Right. You can. You know, there is some correlation between the non-invasive and invasive. When you're talking to a heart failure cardiologist, he'll never look at a non-invasive testing. So you always have to have a swan in to really do it. So anytime if you get a patient like that who's already had some renal dysfunction, who already has significant biventricular dysfunction, I would float a swan and carefully follow the numbers as opposed to anything else. So that's at least at this point, we're not relying completely on invasive measures. But you can. It will definitely add to the value, but not substitute to a Swan-Ganz catheter, at least at this point. Very comparable. There's no question. These are all small observational data. It was just when you put them in the mainstream, really when you look at a bigger hospital setting and put these sicker patients, you know, they really specify the kind of patients that they test them on. But you put them on the real world, it's a different story altogether. So we know it's maybe, I'm sure it's going to come in the pipeline that we may be able to rely on those things. Sorry. So, you know, this is kind of interesting. You know, this, you can look at the dates here, 1967, 1976, some of the KILLIP classification, you know, how you can look at RALs and classify these patients. Boy, the mortality is still, you know, we're looking from 70s, 40, 50, or 5 decades worth. Still the mortality of some of these patients I see as a cardiac index. I don't know how they have it reversed, but anyway. So the, you know, shock really still carries almost the same amount of mortality even now. So I think it's critical to identify that we haven't changed a whole bunch, even with all the devices, everything that we have. Once they get into real shock, the mortality still remains high. And this is the newer Society of you know, Angiography and Intervention came up with, which is a really nicer way. As you saw, the definition was not that granular. Really, you couldn't categorize this patient as to say, you know, what phase of cardiogenic shock he's really in. So the SKY really came up with a nicer one, where you start off with A, which is really low in the risk. And this is the same thing that Dr. Prashad was alluding to. How do we identify some of these patients? I think your clinical acumen, your clinical judgment as to say, you know what, this patient is not going to do well, it becomes critical. So once you think this is a large MI, decompensated heart failure, you want to start acting right here. Then obviously, then he gets into this situation where he gets hypotensive tachycardia. Tachycardia is such an important sign. We miss it nowadays, right? Somebody you're so happy, you put him on either Milrinone or somebody is still tacking away 110, 120. You know, lactate is okay. Transaminases are okay. Renal function is fine. We had a patient like that. It's like 28 years old. Within 24 hours, 120 heart rate. 120 heart rate. Went into biventricular shock, ECMO, TAH. Now is just slowly recovering. Hopefully he's going to get a transplant down the road. It's so important for you to look at tachycardia as it's a simple sign. It's a simple sign. So don't walk away from a patient with tacking at 120, 130. It's as simple as that. And then you go into the classic cardiogenic shock. Here, you know, you're going to need some pharmacological intervention. Maybe that's a time when you need some temporary devices. And then you get into a classic shock which fails to improve despite escalation of therapy. And this is the extremist part where you really refractory shock, everything is collapsed. Now you're calling the surgeons, hey, we're doing a CPR, can you come in and just put him on an ECMO maybe? Yeah, he's gonna do well. So really not gonna do well. So, but anyway, so that becomes extreme. So if we can say, you know, if you look at this pyramid and try and say in a good foundational basis of A or B, if you can try and identify those patients and act on them, I think that's gonna be the way you can get the best outcomes. Very important. So I think the more we know about what this would indicate, this is where you say, you could ask your nursing staff, if you notice these things, this is when you call me, or when you notice when there's a change in the mental status, or when the blood pressure falls, despite being on inotropes and vasopressors. Once you add a second dose of an inotrope, or add a vasopressor on top of that, this is when you start having problems. That's when you communicate. That's when you communicate. Maybe that's when I communicate with my surgeons. and say, you know what, he's requiring dobutamine and another vasopressor. Now I'm thinking about adding milrinone. His index is low, his lactate is just coming up to 2. The communication, exactly Dr. Deeb is saying. So that's when I talk to the surgeon and say, what do you think we should do? Is he viable? What do we have some strategy to go forward with? So absolutely right, Dr. Deeb. So this is one of the ways to do it. But eventually, once we follow this, I would presume that more people following this particular pyramid and communicating with each other, with the team, I think it'll help us understand better to devise pathways based on this. So this is, you're right, this is only to identify which state of cardiogenic shock he is or she is, and then how do we move forward to resort or resolve some of those issues. Yes, communication is number one, but I'm hoping this will lead to pathways to improve care. Correct. Hang on. Well, that's it. So you identify the patient early on in A and B and activate maybe your shock team, activate surgeons, activate other people. So that communication is going to be critical and not wait until it climbs up to there. And majority of the times it's D&E is when we get the surgeons and other people involved, or even our interventional cardiologists involved. Maybe we need to get it early on and see how that works. Yes, communication is the key, but I'm hoping it's going to lead to pathways. And I don't have to tell you these things. There's several causes of cardiogenic shock, as you can see. And you guys know with somebody who come in with acute MI, inferior wall MI, wall rupture, once again, examining the patient is going to be critical. Somebody has a new murmur, has a VSD or a free wall rupture, et cetera. You want to identify those patients, especially in MI. Of course, tamponade, et cetera. And myocarditis is another thing. We had several COVID-19 myocarditis going into fulminant myocarditis. That might be an important situation for you to act early with mechanical devices as opposed to just medical therapy. And arrhythmias, don't forget as simple as atrial fibrillation, uncontrolled. So somebody comes in with acute MI, EF 30, 35%, you keep him in atrial fibrillation with the rates 120, 130, that's too much. That's too much. Just a matter of hours is going to go into a shock. So this just gives you, progression of heart failure is about 11%. Valvular disease going into cardiogenic shock is about 6%. Stress-induced cardiomyopathy is about 2%. Myocarditis might be higher than this. Heart failure actually presented with cardiogenic shock is about 7 to 8%. So majority of the cardiogenic shock, it's going to be LV failure, about close to 80%. And some of these RV shock, RV failure, predominantly RV failure, those incidents are still pretty rare. But majority of them fall into LV failure. And rupture, acute MR, et cetera, you have about anywhere from 1 to 7%. 50% acute MI. I mean, that's what the mortality is. So incidence anywhere from 5 to 10%. Slight decline due to early revascularization for sure. So this is Dr. Prashad was nodding his head. Yeah, that's the case. So he got the answer right on the first gap question. So STEMI versus non-STEMI outcomes may not be different. Worse risk profile in non-STEMI patients. So, what do you think that is from? They have a lot of chronic ailments, so you don't know. You have an acute MI, you just go and fix the artery. Hopefully that'll fix a lot of the problems that they have. But somebody who already has renal failure, already has vascular disease, et cetera, and not actually presenting with an acute MI, those profiles are the worst to take care of with cardiogenic shock, so something to keep in mind. So causes of mortality, we already talked about that. So several of these things. So, I didn't harp a whole lot, but a lot of the times when you bring in the patient, how many people check lactate here on a patient who had a large MI? Lactate, yeah. That's great. It's just the simplest thing to do. You can follow the trend early on. You can identify those patients early on, which might be, you remember, it's already set in the motion of hypoperfusion when your lactate is elevated. So you don't want to wait the lactate to go to 4. If it's 1.9 to 2, you want to act at that point. And these are some of the prognostic scores. How am I doing with time? And these are available online. You can just plug in if you want to. These are all really old data that you could utilize in some of the ICU settings to identify cardiogenic shock. And this is one of the risk score profile. You can get a whole bunch of points in here based on age, acute coronary syndrome, LVEF, blood lactate, GFR, et cetera, and you have a scoring system. You score 900% in hospital mortality. Well, that's not a good sign. So, this might be some of the early ways that you can detect some of these patients in the early phases. Well, you have right heart cath. How many people do right heart cath when you suspect, I'm already adding second inotrope? Okay. So something that might really help you if you sort of incorporate that into your clinical practice. And the more you sort of do it, you get a better idea. Okay, you know what? This patient is probably not going to do well. So it's not a bad idea to do a right heart cath early on. And try and do that through the neck if you can. It's not that hard. The more you practice, obviously, a lot of the people are doing it with the micropuncture technique, et cetera. So it'll be easier for the patient. Even if you discontinue some of the other things, he can be mobile at the same time, participate in physical therapy, et cetera. So this definitely helps you with the cardiac index, goals, and PC, pulmonary capillary wedge pressures. And you can calculate some of the important things because some of the newer trials are utilizing this cardiac power output. This is how it's calculated. It's a very simple calculation. And then same thing with the RV stroke work index if you're concerned about RV heart failure, and LV stroke work index too. So these are simple calculations that you could do and follow them over time to just see how the patient is doing. So the cardiac power index seems to be a very powerful sort of a criteria to utilize. And like I said, this is the calculation in here. So if your cardiac power output is less than 0.5 in some of the trials that they've looked at, the survival is 71% if it's greater than 0.53, and 58% survival if it's 0.5. So the higher the cardiac power output, the better it is. It might be a simple calculation for you to do if you have the numbers. And it's basically, what does cardiac power output really stand for? It's a hydraulic pumping ability and strongest hemodynamic correlate of in-hospital mortality in the shock registry. This irrespective of that. If you see a CPO of low, the mortality is much higher. And this is where one of the just sort of incorporates the pathophysiology of cardiogenic shock. You look at the right and left heart catheterization and consideration for mechanical circulatory support. You can look at the CPI, which is an index, which is a little lower than the CPO, which is the same thing. You index it to the CPO value. So based on this, there's also another component I'm going to introduce called the PAPI, which is pulmonary arterial pressure, which is pulmonary arterial pressure systolic minus the diastolic divided by CVP, which predominantly gives you a right heart function. So you can incorporate CPO and the PAPI together, and this might help you identify some of these patients and say, you know what, I want to act by either adding mechanical circulatory support if the patients are not doing well based on these values. A lot of the cardiogenic shock centers are utilizing just these two variables along with your blood pressure, lactate, et cetera, to identify patients and activate some of the pathways, including surgeons, if needed, to help these patients. We talked about this, which is lactate. You guys already know that. You know about natriuretic peptides. Pulsatility index, yes. Correct. So we want it to be closer to 1.4 or greater, which is really, and then a lot of times the PAPI may improve just by improving the LV side. So something to always keep in mind will help you sort of understand that too. So mixed venous sat, don't forget that. If you have a PA catheter in the pulmonary artery, you can always draw that and follow through. And a lot of times, it's very reliable, actually, if you ask me. They come in with shock. There are mixed venous saturations where you draw the blood off the distal PA port in the pulmonary artery. And if it's really like 30s, 40%, you know that patient is not going to do well. You really want to act at that point. A lot of times you add these inotropes, you go up to 60, 65. That's actually a great sign. So if you're able to follow that, that'll really help you understand these patients where they are in the spectrum. Boy, I mean, this is age old. I mean, this is from 1960, 70, where they actually felt the patient to see whether warm and dry. So just feeling the patient. This is valid even today. Lynn Warner Stevenson did a lot of work in 1990s, but even it was there even before that. So the classic cardiogenic shock is cold and wet. Now, this is where you really want to act and see if you can add inotrope, diuretics, et cetera. A lot of these patients, you would be surprised, their CVP is 15, 20, right? And their RV is dilated, the RV is dysfunction, LV is worse. So a lot of times diuretics per se can actually improve everything. So if you really know these patients well, if they're extremely volume overloaded, just put them on high diuretics. When I say high diuretics, you really need high diuretics. If the creatinine is 1.9, you can't put them on 20 TID of Lasix. It won't work. So you really, because those medications have to be actually secreted into the tubules for it to really work on the glomerulus. So you really have to give high doses of those things. A lot of the patients will reverse back if you identify that early on. So pretty much the same thing. So right heart failure is another thing that, so when you run into a CVP of 16 and 17 and you put them on diuretic therapy, they're diuresing well, but the CVP never falls. So they may have severe TR unrelated to the left side, because you can have severe mitral regurgitation, left atrial pressure goes up, RV dysfunction, you have severe TR as a result of that. If it's all related to left side, the TR actually gets better, the CVP goes down. But there's a primary RV issue, the CVP never goes down. It's going to be such a hard thing to do. So those are the patients you have to really consider biventricular failure in those patients. You could, and they will invariably stay dilated. They'll be like 2.6, 2.8, no matter what. When do you back off on the diuretics? So, those are the patients, that's a great question, because at that point, you really, the creatinine starts going up further. You diurese them, the creatinine starts going up. Then you look at the sodium. That's another thing we look at. Sodium was 132 when they walk in. You diurese, it should get better. Now it's 126. So those are the patients will probably likely require renal replacement therapy to really diurese them. So you want to act early on too. That's a great point. Thank you. I think I should be moving fast here. So this slide basically tells you some of the recovery pathways. So hopefully you're going to move up to the stage A and B from C and D. And of course, when everything, so a lot of the patients stay in stage C is what this slide is going to tell you. So they stay in classic shock C stage before they move to D, which is really worse. So if you can, they stay there for days. So this is where the nursing staff becomes such an important value, because they come in, they tell you the patient is not doing well. If you can try and act when they're in C, you might be able to move up to A and B. So the communication is key at this situation, say what it is. And then you have to spend some time with these patients to really know where they are. You may have to come back a second time in the afternoon, in the evening, just to see where patients are, as opposed to our classic 24 hours. We do that, right? We come in 2 minutes. I do that. Okay, you're doing well. You come back the next day, you look at the labs, it's already worse. So it's too late at that point. So they do spend a lot of time in stage C if you can identify that particular hypoperfusion and shock. And this also tells you the various way you can categorize these shocks. And once again, coming back to the communication part here, so you can say shock severity, how severe they are. What are some of the risk modifiers? You'll be surprised how often these patients are diabetic, running at 250, 300 sugars. You really have to control sugars, because that's crucial to actually help the tissue perfusion. So you want to really help with that. And renal dysfunction, don't forget renal at all. And so those are the things that you have to look at. And then you can classify that as biventricular failure, et cetera. So I'm hoping I can share these slides with you guys, after the talk. So this is another interesting thing. So cardiogenic shock, most common cause of mortality and MI. The older the patient, that's once again Dr. Prashad. Of course, you have an older or sicker patient coming in, you always have to really worry about, those are the patients going into shock right off the bat. So the risk is quite high as you age and coming in with shock. And then the mortality actually increased. If you look at the PCI registry with ACS, 27 to 30%. So really, we're not making a big difference. You take them to this, definitely the mortality is better, but when you compare it to what was happening before and now, even in the almost like a decade, really we didn't make a big difference. That could be because the patients are older, they have more comorbidities when they come in with an acute MI, and now you start doing stents. Still, the underlying milieu is so bad that you may not make a big difference in some of these patients. So something to keep in mind. And of course, your low volume centers performing, a lot of patients go to some of the smaller centers who haven't really handled cardiogenic shock so well. They come in, they do a PCI, they put a stent in. Maybe those patients are not identified early on, and those patients don't do well. So larger centers definitely do better in taking care of some of these patients. And, well, let's put a stent in, take care of the cardiogenic shock. You know, the cost is enormous, some of these patients. So if you have a high volume PCI coming in with a lot of the CS patients you're seeing, the cost per patient is quite exponential. So it's critical that you pay attention. So long-term follow-up is also important. Once they recover from the cardiogenic shock, it's so critical where you're going to plug these patients in. How frequently do you follow? How frequently do you get echo? How do you solve the comorbidities that these patients have? So the long-term care also becomes important in these patients. So once again, I don't want to belabor. There's so many trials in this cardiogenic shock. Some of them are mechanical circulatory support. The same thing, overall, when they're in true shock, you do whatever device you want to do, the mortality is not any better in some of these patients. That's what the whole thing says. Even though there are smaller studies that tells you it's a little bit better, but overall it's not been proven to be better. And this was the latest one that they looked at cardiogenic shock, and ECMO was just published recently. They looked at early ECMO. They come in, they have hypotension, they have a criteria for index being low. They just, one is maximum medical treatment with PCI, whatever they need to do. And the other one, you put them on ECMO and do all those things. Really, the overall, boy, it really didn't help. So even though there was some discrepancy how they chose the patient, who are really in shock, et cetera, once again, it boils down to the definition of shock and how they pick the patient. So it becomes important. So hopefully we'll learn more. There are larger trials utilizing some of these mechanical devices coming in the pipeline. So once again, unifying systems are critical. So no consensus on best practice. Centers are not really equipped to troubleshoot heterogeneous forms of crosstalk, right? We don't know how do we communicate cardiogenic shock with other providers? It's important for you to have a guideline set pathway to say exactly, these are the criteria we're going to look for. This is when we're going to call people to help. And this also tells you about some of the PCI centers. So if there's a patient who is in cardiogenic shock, who goes into a non-PCI center, how do we either transfer him to a PCI center or not? How do we transfer him to a PCI cardiogenic shock center? That's another thing that we have to look at. So there's several pathways that you can do. And there's something called MOBI ECMO. You guys utilize that sometimes. We go into the hospital when they're really sick. You can't transport them. You put them on a VA ECMO or a tandem heart and bring the patient over to the shock center. And this is there's a nicer one. Once again, hopefully I'll share the slides with you guys. They're looking at, this is the Detroit Cardiogenic Shock Initiative algorithm. Very simple one, so it's something that we can also follow if you have to. And how do you really utilize the CPO and the PAPI scores here? You perform the angiography, send them over to the CCU. What kind of things that you want to follow in the CCU? How do you wean off vasopressors and support? And of course, bridge to decision if the patient needs an elevator or transplant. It's the same thing. So medical management, you guys are experts in medical management. We add a lot of inotropes, vasopressors, et cetera. So something that we always use, and there's a whole bunch of things that we can utilize. Some people love norepinephrine, some people love epinephrine. There's really no rhyme or reason how we use it. But I think it's important if somebody who's hypertensive, simple things. Somebody who's hypertensive, 150/90, you don't have to add dobutamine. You don't have to add milrinone. You have to probably diurese the patient. You have to probably add afterload reduction. So it's so important for you to know the trend of these hemodynamics for the patient. So somebody who's in real shock, 1.6, 1.8, cool to touch, those are definitely the patient with hypotension needing inotropes. Yeah. There's a smaller tray that looked at steroid use because you don't have steroids, just covers the whole thing. So you just throw steroids, really the outcomes were not that good. They have, what becomes a little difficult is they may have underlying sepsis on top of that. A lot of these patients end up being on a, so putting them on a big monoclonal antibody and other things might be sort of disastrous at that time to attempt one. So yes, you're right, there's no real randomized controlled trial to look at if this would actually benefit compared to the patients who are not receiving any of those immune modulator therapies. So really, I don't know of any trial that is actively looking at it, but there are some in the pipeline. I'm hoping that they will look at some of these things, including utilization of steroids. And question is, when do you use it? Use it before the onset or during or after? So we don't know the timing also, the dosage, how long, et cetera. We don't know those things. I'm sure we're gonna learn more about it as we learn, well, the pathophysiology. So epinephrine, how many people, I mean, you utilize all of these, right? So there's really no rhyme or reason how to use it. Just know the underlying. So somebody who has a very high SVR, like 1700, 1500, you know, a milrinone might be a better, unless their blood pressure is 80/60. That might be a hard one for you to use a vasodilator or afterload reduction. So you have to be really careful with that. Never forget the other organs. We're so gung-ho about cardiac, improving cardiac output, et cetera. Boy, you have to look at lungs. How often have you missed pleural effusions? How often have you missed interstitial lung disease? How often have you missed pneumonia? Simple things. All of those is gonna make things worse in cardiogenic shock. And renal, never. So if you start noticing kidneys getting worse, the urine output dropping below 30 despite being on high Lasix, don't wait for 24 hours. You really have to get the HD line in, activate the renal, and then we should be able to you know, start CRRT or HD depending on that. You know what? There's always going to be palliative, so don't forget that. Somebody who's 79 years old, I know you want to save him, you want to help him, put him on something, put him on devices, et cetera. You have to ask, is that the right thing to do? So never shun away from getting palliative care involved in some of these extremely sick patients other than just keep dropping devices after devices. Summary. Boy, it's the same thing. So I know I'm so glad that you had a lot of the questions and interactions during my talk. So you really identifying these patients early on is going to be the critical piece. How do I identify early on? Just know your patient well. Know the comorbidities, know the organs involved, and then have a system in place that once you see these parameters, it could be lactate, it could be low cardiac index despite being on dual inotrope, activate those cascades, activate those people to come in together as a group, see if they can intervene early on. That's the best way to do it at this point. I'm hoping, like you said, we'll have some more immunomodulators that we can reverse some of these things. You know, we've had patients, okay, they're in cardiogenic shock, we put them on ECMO, get them on total artificial heart, where you take both the left and the right ventricle out, put a brand new device, which is a pulsatile, which pumps blood, gives you 7.5 liters. Guess what? They're in shock. They're in shock, 7.5 liters, biventricular support. You can't do anything. The tissue perfusion, the lactate buildup, the acid-base balance are so deranged that you really can't bring those patients back up. So something to always keep in mind. Of course, there's so many things that you guys brought up, including non-invasive testing, you know, some of the therapies when they're in true shock that hopefully will help understand better. So the gap question, of course, the answer is that. Don't shortchange somebody who just has heart failure coming in cardiogenic shock. They may have a lot more comorbidities that you may want to act early on. That's it. Thank you, guys. Sorry, that was a whirlwind.
Thank you, Dr. Kalia. Excellent presentation. Any comments from our moderators?
shown any difference in the outcomes as such. So I think if you know the EF is 15%, the LV is hardly moving, and you have a blood pressure of 96/60, my preference is to put them on milrinone, especially if they're tachycardic at 106, 110. That's one thing. Interestingly, sometimes when you start unloading these ventricles with a little bit of afterload reduction and inotropy with milrinone, actually their blood pressure starts coming up, surprisingly. The same thing with diuresis. Even though you're worried about hypotension with diuresis, actually that'll make their hemodynamics better and the blood pressure starts coming up. If they don't, that's a problem. So if you add milrinone on top of that dobutamine, you have a problem. So that's when you really, the cascade has already started rolling. And sometimes you need, norepinephrine. Phenylephrine is another one that doesn't cause a lot of tachycardia. We use a lot of those for vasopressor support, especially if they're in the milieu or they have infection going on top of heart failure.
Okay, our next presenter is Dr. Andrew Bushara. His talk is about hemodynamics in cardiogenic shock, including BIV failure. Dr. Bushara is the director of the heart failure program at St. Joe's Hospital, Dignity Health. He's an associate professor at Creighton University. Thank you for coming, Andrew.
Thank you, Dr. Nseir. Thanks, Dr. Shakur, for having us here. Happy to join you guys here on Saturday. Dr. Kalia went over everything fantastically, so I'll be taking any questions. No, I'm just kidding. So we'll just go over a little bit more, some of what Dr. Kalia already mentioned, but also a little bit more in the nuance of the RV failure, as well as touch a little bit on some of the MCS that's out there in brief overview. I'm not going to talk about ECMO a lot because we have great speakers coming up to talk about ECMO and cannulation strategies. So I'll leave that to the experts in the field. So no disclosures. So I'm not going to focus on this too much. Dr. Kalia went over this fantastically, but as we know, shock in its early stages, when it was first identified in the 60s, had very poor mortality, first identified in the AMI population, but slowly over the years, we've kind of began identifying more and more people who are in different phenotypes of shock and cardiogenic shock specifically, and we'll touch base on that. So in the beginnings, they defined as the failure of the intensive care to improve mortality rate from shock represents a continuing challenge in the current therapeutic concepts that were available at that time. This was back in the 60s. Dr. Kalia went over this quite eloquently, where shock is a state of cellular tissue hypoxia, and it's tripartite with reduced oxygen delivery, increased oxygen consumption, and or inadequate oxygen utilization. And what he stressed, and what I'll stress again, is the key feature here is early identification and early implementation of therapeutic strategies. This is how you save these people. Once they proceed to the point where it's no longer a hemodynamic problem, but also a hemometabolic problem, that's where these patients suffer and where it's very difficult to turn them back. So when we talk about shock in general, there are four broad phenotypes of shock: cardiogenic, distributive, hypovolemic, and obstructive. And then there's this phenomenon of mixed shock, which we not so infrequently encounter. And these are much more difficult patients to treat, because it's no longer any strategies that we start thinking about implementing, especially in the mechanical support realm. They really improve the cardiogenic aspect, but once you're dealing with other aspects of shock, then these patients really don't do as well. So when we talk about the hemodynamic profiles for the different subtypes of shock, cardiogenic classically with a high preload, reduced pump function, high afterload, and reduced tissue perfusion. And really the distinguishing feature between that and distributive shock is distributive with a higher output and lower systemic vascular resistance, and hypovolemic with relatively normal cardiac output or index and high systemic vascular resistance. Dr. Kalia went over this again, defining cardiogenic shock. One of the mainstays is the systolic blood pressure being reduced less than 90 One key thing to remember here, it's a sustained blood pressure reduction. So these transient patients, after a PCI or after medication induction, patients, like just the other day, there was a patient AFib RVR, low EF, got diltiazem, temporarily had reduced blood pressure, but then bounced back. These are not the shock patients that we're talking about. We're talking about the ones who have sustained low blood pressures for at least 30 minutes, despite catecholamines, despite vasopressors or inotropic support. That's the hemodynamic initial definition, and then that's coupled with right heart cath parameters, which include your cardiac index less than 2.2 and wedge pressure greater than 15, with associated metabolic derangements, low urine output, altered mental status, and lactate greater than 2. It's important to note, and Dr. Kalia kind of touched base on this briefly, is that the etiology is very important here, because the ones that present with AMI shock are much different than the ones that present with acute decompensated heart failure and then proceed into shock. The ones who are AMI shock, this is primary pump failure is how they present. But the ones that present with acute decompensated heart failure that then go into shock, remember these patients are used to living in a relatively anaerobic state for most of their life. So the ones that proceed into shock from a decompensated heart failure standpoint, who are chronically decompensated, these are typically patients who have high afterload or high preload as a result, or as an initiating factor leading them into the shock state. So typically targeting preload and afterload in these patients goes a much longer way than just sticking them on inotropes right from the get-go. Common causes of cardiogenic shock, predominantly LV failure, but also a little bit of a distribution in terms of tamponade, VSD, acute severe MR, and RV shock. So why does grading shock matter? Grading shock matters for 3 reasons. One, you want to prognosticate these patients and see who's gonna, or try to think of who's gonna do well and who's not gonna do well, and needs to be surveyed a little bit more closely and maybe have an ICU stay or more close lab workup and monitoring. It's also important in the sense of coordination of care. You want to both initiate therapy early, but also think long-term. If these patients can't be weaned off mechanical support, we need to get them to a place where they're gonna have exit strategies or options, whether they be LVAD, whether they be heart transplant. And then finally, it's important in the clinical decision-making aspect in terms of determining the timing and therapies, both mechanical and medical, that are available for these patients. Each institution has its own gamut of mechanical circulatory supplies, devices that they're comfortable putting and comfortable managing, and others may use different devices. So it's really an institution-specific process when it comes to these. Dr. Kalia went over this very eloquently. We won't really focus here. The SKY consortium came up with more defined parameters for each of their stages A through E. And really, the classic shock sets in at stage C when you have your low blood pressure with right heart cath parameters meeting cardiogenic shock, and are not improving with just your typical inotropic or vasopressor support. These patients typically, if you look under biochemical markers, they'll have a lactate greater than 2, they'll have creatinine doubling or more than a 50% drop in their GFR. You'll start to see evidence of end organ dysfunction other than just renal. You'll start to see increased LFTs and other clinical signs like altered mental status and decreased urine output. So these are all things that, whether the patient's in the ICU or on the floor and you have a high index of suspicion of a patient that may not do so well, communication is key, both from the ancillary standpoint as well as from a team standpoint, making sure that everyone's on the same page and carefully monitoring these patients. When it comes to evaluating RV shock, I was actually just in Denver this past weekend. They held the ISHLT conference, and they're presenting the updated guidelines for acute MCS. This is actually, I don't know how to use a pointer here. Right here, their guideline came out in the end of March of this year, and I'd refer all of you guys to kind of take a look at that. It has great hemodynamic discussion as well as overviews of all the devices that are available, anticoagulation guidelines, and really is helpful when we're thinking about approaching this very tough patient population from a multidisciplinary standpoint. So when it comes to RV shock, it's a little bit more nuanced, and this table is actually taken from that guideline, the ISHLT guideline that was presented in Denver. But really, I look at three different parameters when it comes to evaluating patients with RV shock. So you can look at the CVP to wedge ratio. The cutoff differs whether it's a patient who's in chronic heart failure presenting in shock or a patient who's presenting with acute RV failure. So typically when we look at the CVP to wedge ratio, I use a cutoff of 0.63, greater than which is a sign of poor prognosis from an RV standpoint. In a chronic RV failure setting, a CVP to wedge greater than 0.86 in an acute RV failure setting is a poor prognostic sign. When it comes to PAPI, as we kind of discussed earlier, a ratio less than 1.85 in chronic and less than 1 or 0.9 in acute is a poor prognostic sign. And then RV stroke work index is a little bit tougher to do off the top of your head. So typically these two are the ones people will use more closely. But an RV stroke work index less than 300 is, again, a poor prognostic sign. Yeah. Yeah. So are we saying a patient who has a swan or no swan? Has a swan. Okay. So a patient who has a swan, you're going to look at, you can use your PA diastolic as a correlate of your wedge pressure in most cases. So if you're noticing that your CVP is very close to your PA diastolic, that's an RV that's struggling. Okay. If you're noticing that, and PAPI is easy to calculate because when we have our swan GANs in, you're already seeing the CVP and you're seeing the PA, oh wow, you're seeing the PA systolic and diastolic as well right in front of you. So that one's pretty straightforward. The wedge, you won't get it unless you wedge the patient, right? So that's what I would always use, just PA diastolic as a correlate for your wedge pressure in these patients. In patients who don't have a swan, it's a little bit more difficult, right? You can use bendopnea or orthopnea as a correlate for your left-sided filling pressures, and then your JVD as a correlate for your right-sided filling pressures. So if you on clinical exam, absolutely, yep, absolutely. In patients who don't have a swan, definitely you can use that as a clinical exam finding. And when they looked at correlates of physical exam to hemodynamics, they found that JVD was actually one of the strongest indicators and strongest correlates to hemodynamic CVP measurement. Yes. Yep. Yep. Absolutely. Correct. 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 Yeah. Right. No, absolutely. And for those that, the residents and students that do round with us, I do stress it as a point on physical exam. I ask them, what's your JVD assessment and where would you put it? And I ask them to give me a specific number, not just present or absent. So typically, I tell them if the patient's sitting upright, use 10 as your base, and you add 4.5 above the angle of Louis. Patients who are supine, completely flat, you use a base of 5 and add whatever the distance is from the angle of Louis up to the height of the pulsation. And then patients who are more on a degree of 45 to 60 use 8 as your base and then add up to the angle of Louis. So it really depends on what position the patient is in. But I do stress for our students and trainees that they do give me a number because I want them to get used to doing that regularly on their physical examination. Yep. Yeah, so IVC is a little bit more nuanced as well because remember, a lot of these patients may be on a ventilator, and your IVC is going to be engorged when a patient's on a ventilator because of the changes in intrathoracic pressure. So IVC is a good tool. If it's very dilated, then you have your answer. But if it's in the range of like 1.8 to 2.2, it's very difficult to say that just based on IVC whether to diurese or not diurese. So we use it. Now, is it great? No. I would still definitely use a swan instead of that if available. But it is one of the measures that we do use. Yep. We know from LVAD data that it's very hard to predict who's going to proceed into RV failure post-LVAD. There have been several scores that have been developed, both the Euromax score as well as the Michigan score, that take into account both symptoms, clinical criteria, vasopressor requirements, and measures of end organ dysfunction to evaluate preoperatively patients that have a high risk of proceeding into RV failure post-LVAD. As you guys know, RV failure post-LVAD is a difficult thing to work with. And really the area under the curve for even these scores, the best scores out there, area under the curve is still only 0.7. So you can tell from that even despite these scores, it's still very difficult to predict who's going to proceed into RV failure. Dr. Kalia went over this as well as far as mechanistic development of cardiogenic shock. Both from an acute pump failure, acute MI standpoint, starting up top, as well as patients who are more of the anaerobic, chronic decompensated heart failure patients that then have an inciting event, whether it's extra volume on board or high afterload that kind of portends a worse prognosis and sets them into a cardiogenic shock state. Acuity matters. So acuity matters because in the AMI realm and the chronic realm, it's different. Remember, in the chronic realm, like we've been saying, these patients in this pressure volume loop, these patients live in a chronically elevated volume state. So there is an inciting event that kind of tips them over into a slightly higher volume state. But remember, they're used to living in this state for quite a long time. So it only takes a little bit to push them over the edge. In an acute setting, patients typically live in this gray zone, and then they have an acute MI that kind of pushes them over the edge here on a higher volume state. But if you compare where these patients live initially to where they end up, it's not a huge change in terms of volume status. So this is mostly, the big thing here is a pump failure, a reduced contractility, where you go from this end systolic pressure volume relationship on the gray here to the red. That's this line coming down here. So in the chronic patient is not a huge drop in contractility. It's more so the change in systemic vascular resistance and volume that typically tips the chronic patient over the edge. Dr. Kalia went over this, so we won't focus too much on that. There is different hemodynamic profiles within cardiogenic shock itself. The classic patient is the cold and wet patient, but you can also have the euvolemic cardiogenic shock, where this is typically the patient who may present with an acute MI situation and may not have had that plenty of time to develop volume overload, but had an acute pump failure, acute drop in cardiac output, cardiac index due to their MI. The vasodilatory or mixed cardiogenic shock, these are classically your cardiogenics who are also septic or have another vasodilatory component to their shock. These are very difficult patients to treat because all of the available gadgets and toys that we have out there only hit the cardiogenic component, but they're still suffering from the septic component most of the time. If they do have a strict vasodilatory shock with an increased cardiac index, this is a septic-only patient, not a cardiogenic patient. One thing to remember when it comes to physical exam, on exam, cold patients are in shock, warm patients may still be in shock. So just because we feel that they're warm, their extremities are warm on exam, if they have other features of shock, altered mental status, the low blood pressure, rising lactate, low urine output, do not rely on warm extremities as the only thing keeping them out of shock. So these patients, I would still be very vigilant in doing a right heart cath and making sure that we're not dealing with a low output state. As far as risk markers portending worse prognosis, Dr. Kelly went over these very well, so I won't spend too much time here. I do want to leave some time for questions at the end. Diagnostic evaluation, CBC, CMP, coag profile, ABGs, central gas. If only a central line is available, we can also use central gas to kind of guide us as far as escalating support for these patients. Serial lactic acids and serial cardiac troponins. Troponins are prognostic in this situation, not diagnostic. All cardiogenic shocks should have a 12-lead EKG to rule out MI and other arrhythmias, as well as a chest X-ray and comprehensive echo. So current guidelines, class 1 indication for cardiogenic shock patients to use intravenous inotropic support to maintain systemic perfusion, preserve end organ performance. We all know this. This is not new information. In patients with cardiogenic shock, temporary MCS is reasonable, and we'll talk about situations where we need to escalate in terms of maintaining cardiac function when pharmacological measures are not enough. And then a class 2A indication as well is a multidisciplinary team. I cannot stress this enough. Both in Detroit, this was stressed, as well as here it needs to be stressed. A multidisciplinary team that's experienced in the shock state is reasonable. So this MDC team that has been developed is a team that consists of both the referring physician, as well as a shock coordinator, interventional cardiologist, heart failure cardiologist, cardiac surgeon, as well as a critical care physician. And it is through multidisciplinary discussion that we come to the best treatment strategy for these very complex patients. So these are just recommendations taken from the new guidelines and the ISHLT HFSA guidelines that were presented end of March. They again stress the multidisciplinary team, early activation of the team, as well as support when failing pharmacological measures. They also stress the importance of teasing out severity and presence of aortic regurgitation. As we know, many of our devices are not compatible in patients who have quite significant aortic regurgitation, and some devices are actually preferred over others in those situations. So very important for that initial echo prior to escalation of support to tease out this presence of and severity of aortic regurg. The two main cornerstones of management are, one, to restore adequate end organ perfusion. This is your PCI in patients who present with acute AMI shock. And then also to unload these patients from a ventricular standpoint and reduce the work on the heart. We'll skip over that. So in terms of hemodynamic monitoring and cardiogenic shock, class 1 indication in patients who have respiratory distress or are failing the initial management strategy, whether it's diuresis, whether it's afterload reduction, and where you have a high index of suspicion of thinking these patients have a low output state, these are the patients that you want to SWAN and get more data. As far as management, we know that initially it starts as pharmacological with vasopressors and inotropes, as well as targeting the underlying etiology for the shock, whether it's AMI shock or otherwise, with coronary revascularization. And really, the end goal here is either a bridge to recovery in the acute setting, or if patients are not able to recover cardiac function or be weaned off of vasopressor, inotrope, mechanical support, then consideration for durable mechanical circulatory support or heart transplantation in these patients. So we'll talk about each of the three parts, preload, afterload, and contractility, and kind of go over goals in the shock patient and some caveats that we have to have and keep in the back of our heads. So typically when it comes to preload, they advocate for using a CVP goal of around 10 to 12. I sometimes use a goal of 8 to 12 in certain patients. But again, remember the caveat here is your mixed shock patients. So patients who are presenting with mixed vasodilatory as well as cardiogenic shock, you want to use a more liberalized goal, as well as those who have biventricular shock. Like we kind of mentioned one of the comments earlier, that if your CVP is quite elevated in comparison to your wedge, diuresing them to a normal PA diastolic or normal wedge is going to sacrifice your end organs. So you're going to have to allow for a little bit of elevated ventricular filling pressures, especially so on the right side in patients who have more predominant RV shock compared to LV shock. When it comes to afterload, in a patient who has reduced EF, they're a very afterload sensitive type of heart failure. So if you look on the left-hand side there, your curve for a normal patient who has a normal EF, you see that if you reduce mean blood pressure, you don't really get a huge increase in stroke volume. But a patient who presents with severely reduced LV function, if you reduce your mean blood pressure even by a little bit, you get quite significant increases in stroke volume. So that's why it's important to remember that if these patients have blood pressures of 130s, 140s, and an EF of 10 to 15%, these are very afterload sensitive patients. These are patients you might consider using nipride on up front to try and reduce their systemic vascular resistance. And you can see quite significant improvements in cardiac output and cardiac index in these patients. So when it comes to targeting systemic vascular resistance, the typical goal we use is 800 to 1,000 dynes per times seconds over centimeters to the fifth. But remember, you want to reduce filling pressures to near normal without compromising their preload. So remember, the equation here is MAP minus CVP. That's your renal perfusion pressure. If you have a patient who's still quite volume overloaded, you don't want to reduce the MAP too much until you've adequately diuresed the patient first, because otherwise then you're going to be sacrificing the amount of blood flow and output to the kidneys, and they'll suffer because of that. When it comes to inotropes and vasopressors, just like Dr. Kalia kind of already touched on, there's little evidence to inform the use of one agent over the other. Typically, if a patient has a low MAP or low systolic blood pressure less than 90 or 80, or a MAP less than 60, the vasopressor of choice is levofed in most of these patients up front. And it's had good data both in the septic realm as well as the cardiogenic shock realm. So this is the favored first pressor in most of these patients. When it comes to using or deciding between milrinone or dobutamine in patients who have cardiogenic shock with a relatively preserved blood pressure, remember, you don't want to institute dobutamine or milrinone in patients who have a systolic blood pressure of 80s or 90s. They're not going to do well in that case. So these are patients that may need dual support as far as both vasopressor support and inotropic support. Typically, my comfort zone with these patients is a patient who has systolic blood pressure in mid-90s to upper 90s, I'll use dobutamine. Patients who have a systolic blood pressure in the low hundreds to 110s or so, I'll use milrinone, because milrinone does have a more significant reduction in systemic vascular resistance. You have a bigger blood pressure drop with milrinone up front, so just keep that in mind. Um, Absolutely. Yep. So remember the mechanism of action for these drugs, and I think it's coming up on in a few slides. But milrinone is you are able to use that in patients who are chronically beta blocked because it has a different mechanism of action through the phosphodiesterase pathway rather than dobutamine, which acts through the beta agonist receptor pathway. Yep. 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 Yeah, so that's actually what I was saying. So patients who have a lower blood pressure, like in the 90s, I would use dobutamine over milrinone in these patients because you do see sometimes that increased blood pressure effect up front. I don't use milrinone in these patients unless you have specific indications, like patients chronically beta blocked at home. So. Another reason where you might favor milrinone is in the reduction of pulmonary vascular resistance. Milrinone typically has a better effect in that realm. Um, but when they looked at milrinone versus dobutamine head to head in the DOREMI trial, which came out a few years ago, I believe, they didn't see any difference as far as mortality or hospitalization. So in the end, it's up to the individual physician, individual institution, but those are some of the typical guidelines I use in choosing one over the other. And then remember, lastly, in the patient who has very afterload sensitive heart failure, nitro for your preload elevated patients, as in addition to diuresis, and then nitroprusside in the high afterload state heart failure. These can go a long way in improving your cardiac output, cardiac index in these patients. Dopamine over dobutamine, no. Yeah. So as far as each individual vasoactive agent out there, again, norepi is predominantly a vasoconstrictor with some mild inotropic effect. I would not use norepi if you're looking for a strong inotrope. This is mostly a vasopressor. And so it's your first line vasopressor for cardiogenic shock in the ED. Phenylephrine, typically not a first line agent, though it does have a niche use in patients who have elevated LVOT gradients in HOCM patients. This is your go-to as far as vasopressor support in these patients because it does not increase your inotropy, which can be very deleterious in a HOCM patient. Vasopressin is typically our second line agent for vasopressor use. The good thing about vasopressin is it does increase your afterload, but not in your systemic circulation, but not so much in your pulmonary circulation. So that's important in patients who have chronically elevated PA pressures or a high pulmonary vascular resistance. It might be a good choice in those types of patients. Epinephrine is an inoconstrictor. Typical uses are in symptomatic bradycardia and refractory hypotension, typically as a second or third line agent. Epi have found good observational use for it in the patients who have RV failure, and you're looking for an inoconstrictor in that setting. Epi is very good. Remember, with RV failure, these patients don't tolerate low heart rates, so epinephrine is good both in raising blood pressure and heart rate in these patients. Dopamine is an inoconstrictor, but again, really in the bradycardic patient, I don't typically use it as one of the first line agents in cardiogenic shock patients. And then our inodilators, dobutamine, milrinone. Dobutamine is typically easier for the ED to institute up front because it's more short acting and they can see effects immediately. And if they see deleterious effects, they can shut it off and its effect goes away pretty quickly. So our emergency department colleagues like to use that as the typical inotrope up front. Milrinone, slower acting, longer half-life than dobutamine. Remember, it's renally cleared, so those who have CKD or are on dialysis even, the dose that we're using is lower than the typical patient if we're using milrinone. And it can accumulate in those who have renal dysfunction, so keep that in mind. So when we talk about the pressure-volume relationships for each of these vasoactive agents, remember, nobody loves these graphs because they always cause headaches during board exams. But in any case, the high preload patient here represented in red, you're going to try and get them back to a control state, and you're going to do this by nitrates and diuresis, and that's how you get them back here. This is just, we're talking just from a medical standpoint. Obviously, MCS will help in this regard as well. For those who have a chronically elevated or acutely elevated afterload state, nitroprusside or blood pressure reducing agents are what are going to get you back to the control state. And you can see that when you go from this darker red to the black line here in the middle, that you get quite significant improvements in stroke volume. Stroke volume is represented by the width from the isovolumic contraction here to isovolumic relaxation. The width is represented by your stroke volume. So you can see both with reduction in afterload and preload, back to a control state, you get quite significant improvements in stroke volume. And then obviously your inotropes, patients who have a reduced inotrope state or your chronic decompensated heart failure or acute MI patients, adding inotropes basically increases the slope of this end-systolic pressure-volume relationship, and that improves your stroke volume. You can see improvements with widening of the curve there for stroke volume. It's important to remember, though, that with inotropes specifically, you do get improvements in stroke volume, but it's at the expense of increased myocardial oxygen demand and consumption, especially in the long term. In the acute setting, it's okay, but in the long term, this is what we worry about from an advanced heart failure and general cardiac standpoint. So remember, when you're starting to add a second inotrope or a vasopressor, these patients have an exorbitantly higher mortality risk. And these patients, before you've done that, you should really ask yourself, should I go for that second agent, or should I start considering mechanical circulatory support here to unload the heart? So Dr. Kalia quite vividly talked about CPO, so we're not going to talk about that too much. But once you've instituted medical therapy, pharmacological therapy, you start wondering, is your patient going to be okay, or are they going to start decompensating? And so this is where serial testing and scoring systems and keeping a close eye on invasive hemodynamics goes into play. This is published from Dr. Basir out in Detroit. And basically, they looked at just a plot of cardiac power output and lactate, and they found that the patients who had cardiac power output less than 0.6 and lactate greater than 4 had dismal survival, 31% survival at 12 to 24 hours, whereas those that had a higher CPO greater than 0.6 and less than 4 for the lactate had a 95% survival. Obviously, this is institution dependent, and keep that in mind, but these are important ends of the spectrum for us to keep in mind, and really the patients who are in this middle zone, you should really keep in mind, are they going to favor well, or do I need to start thinking about mechanical circulatory support in these patients? We'll skip this. So as far as temporary MCS, just to briefly touch on, there is a golden period, and once acidosis sets in, this is too late, okay? So once acidosis sets in, this is where you're in your cytokine immunomodulatory dysfunction stage, and this is where no matter what kind of mechanical circulatory support you're going to institute, whether it's left-sided, bi-V, RV, these patients are not going to fare well. So really the time to act is the golden hours and early silver days, where you have early multi-organ dysfunction, if at all, before SIRS sets in. These are the patients that you're going to be able to bring back. And then remember that The choice of temporary MCS is going to be patient-specific characteristics. Is it BIV? Is it LV? Is it RV failure predominantly? It's going to depend on operator. It's going to depend on institution and expertise available, what devices the institution is comfortable placing and managing, and then recommendations that come from a multidisciplinary team. So timing matters, like we've been talking about. So once multi-organ dysfunction or this idea of hemometabolic failure sets in hospital mortality is going to be high despite what you do. So with 0 end organs being involved, mortality is about 30 to 40%. With 1 organ involved, slightly raises mortality to about 38%. Once you get 2 organs or more involved, and this could be as much as liver and kidney, you've already reached 48% mortality there. So in terms of a decision algorithm, things to consider, what was the status of the heart before the shock? Is it an acute pump failure or is it a volume afterload failure? Which ventricle is failing? So if your index is low, CPO is low, and PAPI is low, think of BIV failure. If your PAPI is okay, greater than 1.5, and your CPO and index are low, think of predominant LV failure. And if your PAPI is low and your index is borderline or low and your CPO is otherwise relatively okay, think of predominant RV failure. The other thing to keep in mind is how much flow do you need, and that's going to depend on your patient's body habitus and size. So typically when I think about choosing a mechanical support device and talking to our interventional and cardiothoracic colleagues, I think about using an index cutoff of about 2.2. You take 2.2 and you multiply it by the patient's BSA, and that's pretty much the amount of cardiac output that they're going to require to sustain the whole body. So using that as kind of a makeshift calculation, you can kind of think of, well, what kind of mechanical circulatory device is going to be enough for my patient? The other thing we need to keep in mind is, do we need to oxygenate the patient? That's going to determine also what kind of MCS device you'll choose. And then finally, and very importantly, is do we have an exit strategy for this patient if they fail to come off of mechanical circulatory support? So this is a good lower half here to keep in mind as far as how much liters flow each device kind of provides, and then keeping in mind the patient's body size. That'll help determine the amount of or what mechanical device to choose. This is unadjudicated data that came from Dr. Kapoor in his own experience. And they found that, you see, in the SKY stage D and E patients, using an isolated LV or univentricular support system is no longer enough in these patients. They have high mortality despite mechanical support just for one side. So once your patient starts heading away from stage C into stage D, you're going to have to really start thinking about utilizing biventricular support systems rather than just univentricular support systems. And this is what they termed hemometabolic shock as opposed to just hemodynamic shock. This is an algorithm that's out there. I'm sure many of you have seen this before in terms of deciding on which kind of shock the patient's in first and foremost, and then what kind of support they may benefit from. So in terms of the types of MCS out there, this is out there in the literature. I won't delve too much on this. Just for a quick overview, balloon pump is readily available or should be readily available. It does not give you a huge increase in cardiac output, maybe 0.5 to 1 liters. It is good because it can be done at bedside. It's a pretty cheap device, but remember its contraindications: cannot be used in severe AI. You do need relatively regular heart rate for the balloon pump to augment appropriately, and then it's associated with some negative consequences such as balloon displacement, rupture, or leak. These are things to keep in mind. So the main benefit here of the balloon pump is reducing LV afterload and decreasing wall tension and oxygen demand, meantime increasing your diastolic coronary perfusion. When it comes to our transaortic valve devices. The Impella device is 2.5 CP and 5.5. These can come in a different variety, both in terms of sizes and access sites. The predominant benefit of these patients is our active LV unloading. Flow is going antegrade into the ascending aorta, does not require venous access unless you're using a very novel way of putting in the Impella. Back in Detroit, they used transcaval access in patients who did not have, who had significant peripheral arterial disease. And so these patients might benefit from alternative access. But remember, moderate severe AI, mechanical valves, severe AS, severe PAD, right heart failure, these are all things to keep in mind in patients, and they may not benefit. I'm running short on time, so would you guys like me to continue over these devices? Okay. So the tandem heart device is an LA to FA pump, increases blood pressure, total cardiac output, and decreases wedge pressure. The beauty of this configuration is unloads your LA, secondarily unloads your LV because it's not technically sitting in the LV. You can use it in small LV conditions. You can use it in AI pretty well, and you can use it primarily in patients who have LV clots. So this is where you don't want an Impella necessarily sitting in the LV. Cons is it is technically more involved than putting an Impella in. It requires a transeptal puncture. There are stability concerns, leg access. Only cannot use if there's an LA clot as opposed to an LV clot, and you do need fluoro for placement. In terms of RV support that's out there, remember it's going to depend on whether you need an oxygenator or not, but some of the support devices that are out there, the Impella RP, it's active RV unloading, can achieve flows of about 4 liters per minute. It is rhythm independent, so it's important to keep that in mind, but you're not going to be able to use it in patients who have severe PI or mechanical tricuspid or pulmonary valves. You cannot use it with an oxygenator, so if you do need an oxygenator in a patient, this is not an option. And then also keep in mind that RV clot rules the patient out of this device. The Protect Duo, through our Tandem colleagues, unloads the RA-RV. It does achieve similar flows of about 4 liters per minute, can be used in small RV conditions, is also rhythm independent. It is IJ access for 29 or 31 French dual lumen catheter. But again, similarly, keep in mind your valves, so mechanical TVRs, PVRs, or severe PI are contraindications to this process, and you do need fluoro for placement. Centromag is an extracorporeal, surgically placed support device. It can be both an LV and RV support system and allow you to achieve flows of about 10 liters per minute. Typically in the cardiopulmonary circuit bypass pathway, it's used as 6 hours support time, but can be used up to 30 days if it's extracorporeal to support either ventricle or both ventricles. Hemolysis is reduced in this configuration because mechanical gaps in the pump are also reduced, and there's decreased shearing forces. Keep in mind, bleeding, infection, CNS, and respiratory failure are some of the things to watch out for. In ISHLT, they presented a new device that they're investigating in Europe called the PerCat RV pump. This is going to be the first pulsatile right-sided support system. Data is still preliminary. It is modeled after the balloon pump and mostly advertised for the right side currently. So it's currently undergoing trials in humans, but they showed that it achieved comparable flows of about 4 liters per minute. And really the golden thing for it is the pulsatility for the right side. So these are some of the consensus documents that are out there. Just a question to conclude. So a 55-year-old male, prior EF was normal, presents with cardiogenic shock due to an acute STEMI, has renal failure, has liver failure, and has a narrow pulse pressure and salvos of VT. His BSA is 2.37, and those are his measurements up there, cardiac index of 1.2. So question becomes, what is the intervention that is most likely to fully normalize this patient's cardiac output? And so remember that this patient is going to be different than your female, 55-year-old female who has chronic heart failure and known EF that's low and it's admitted with cardiogenic shock and has an inciting event that just tips her over the edge. She's a smaller BSA patient. And so if we use the cutoff of an index of 2.2, her goal cardiac output, she only requires about 3 liters, whereas your gentleman will require about 5 liters. So the choice of MCS device is going to be very different between these two patients. So just remember, cardiac output is not additive. And that's all I have. Thank you very much. So happy to take any questions in the meantime until Dr. Nseir is able to introduce anybody.
What interventional cardiologist or a general cardiologist such as myself involve you? And do you have some sort of algorithmic approach to when we should be calling your team? And what is the red flag or algorithm that we should be implementing?
Yeah, great question. So just like Dr. Kalia kind of touched on a little bit, and he can definitely add to that. So once a patient is having a rising lactate or the patient is starting developing signs of end organ dysfunction, that's where you need to act. Once the lactate exceeds about 10 or so and the acidosis sets in, then it's too late. So we want to be notified before acidosis. Once you're starting to see signs of end organ dysfunction getting worse, that's the time to act and escalate mechanical circulatory support. If a patient's already on MCS support and is either deteriorating or stable and not weanable, those are the patients you also want to call about, because those are the patients that we're going to start working up for more advanced therapies like heart transplant and LVAD implantation.
Everything that you said, I completely agree. So if you start adding additional, let's say you put him on a little inotrope, dobutamine of 3, 5, and he's okay, he's maintaining well, his organs are fine. Once you start adding milrinone, his index is falling, his renal function goes down. So anytime you start seeing a secondary or any other organ damage starting to set in, or you want to start a CRRT, et cetera, I think that's the earliest time that you probably want to involve the team.
How do you interpret the mixed venous oxygen numbers?
So are we saying for a patient who just has a central line in place?
Yeah.
Okay. So for central line, actually, and pulmonology has been, depending on which institution you're at, and this was presented at the meeting as well, there's a lot of hesitancy about doing swans in the general community. So for patients who only have a central line, I would use just the SVC saturation as a correlate, because remember, once you're thinking about your mixed venous set, it's going to be 3 SVC sets and 1 IVC set over 4. And so when you're using your mixed venous set as a correlate for your PA set, whatever your SVC set is, your PA set should be a little bit higher than that overall. So SVC set, I use it kind of as a lower limit, a lower threshold. So if a patient's SVC set is normal or high, typically I'm not dealing with cardiogenic shock in these patients. Typically, if it's about 65 or higher, and they're not on inotropes, they're not on pressors, and they're still in shock, I'm thinking of some other sort of reason for the shock. If the SVC set comes into the about 40s, like Dr. Kalia, 40s to 50s, and a patient's in shock, you might be dealing with isolated cardiogenic or mixed shock. But once the set is that low, I really advocate for more hemodynamic profiling with the swans in these patients, because just using the set as a correlate alone is not enough. We don't know what's happening with the PA pressures. We don't know any of that data. So it's a good first measure to kind of push you one way or another. Is it mixed? Is it cardiogenic or is it septic. But once it gets to the point where, based on the set, you're suspecting a cardiogenic component, then these are the patients you really want more hemodynamic profiling with the swans. Yes. Yep. Absolutely. When it comes to device wean, um, I do still advocate for the right heart. If it's available, I do advocate for the right heart cath because, again, you get to more closely see what's happening with PA diastolic and wedge pressure when it comes to that.
Sometimes in certain situations, such as severe tricuspid regurgitation. So we're advocating more in our cardiac realm at Chandler to correlate, get a thick cardiac index. We can use the mixed venous O2 sat with some other variables to calculate a cardiac index and compare that to our thermodilution to verify that we can either rely on our thermodilution technique or say, hey, we think there's an issue here, maybe severe TR, that's causing our thermodilution to be off. So we use it a lot from the medical ICU and the intensivist perspective to make sure that our numbers are reliable and that we're relying on good numbers.
Yeah, so just like Chris was mentioning, remember your FIC is more accurate in your low cardiac output states. Your thermo is more accurate in your higher septic cardiac output states. So I will always prefer a FIC over a thermo in the patients who are proven or suspected cardiogenic shock.
Thank you. On mechanical ventilatory support with varying degrees of PEEP. So how do you factor in your PEEP when you're trying to optimize volume status?
Yeah, absolutely. So patients who are requiring a high PEEP, I'll usually use a more liberalized CVP goal in these patients, especially so patients who are on ECMO. Patients who end up on ECMO, if you drive their CVP down to 8, you're going to start getting suction alarms on the venous side of things. So typically, I'll use a more liberalized goal of 12, maybe up to 15 in some patients. Patients who have combined shock, like septic shock as well on the ventilator, I'll use a more liberalized goal of up to 15. Typically, up above 15, I don't see any benefit in leaving them hanging above 15. Typically, these patients, you can diurese to a quite significant amount and optimize them both to wean them off the vent and wean them off mechanical circulatory support. So 15 is where I use my upper limit threshold, and Dr. Kaya can provide us with what his threshold is as well if he'd like. But that's what I typically use. Mhm. Yeah. 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 Yeah, great question, Dr. Deep. So actually in Detroit, we used it a lot. Here, not so much what I've seen so far. So the balloon pump is not the choice when you want a really good increase in cardiac output. It does not give you that, okay? What the balloon pump gives you is the afterload reduction, okay, and the coronary perfusion. So it's a good device in a patient who has chronic heart failure and then becomes acutely decompensated to the point of shock, because these patients, like we were talking about, are very afterload sensitive. And if they have a high afterload at the outset, putting in a balloon pump can really reverse that state. In the patient who's presenting with acute AMI shock, balloon pump is not your choice for those patients. And typically they require much more support than a balloon pump can provide.
Just one quick question, Dr. Bashara. Thank
Yep.
you. That was a great presentation.
Thank you.
we in our cardiac ICU where I trained, we were a little more cautious about central venous pressures and necessarily making the assumption that pressure and volume are kind of strictly correlated to each other. What is your approach to interpreting volumes and equating them to pressures, as opposed to say maybe do we consider further unloading or afterload reduction and something like that? What is your approach to that?
Yeah, so great question. We don't have a good answer for that. So all of our data that exists currently is utilizing pressures as correlates for volume, and it sometimes works. Most of the time it works. Sometimes it doesn't work. So unfortunately, there's no clear answer for that. But the best that we have currently in the community and general cardiology and interventional community out there is using pressures as our correlates for volume. This is sometimes where you kind of try to correlate physical exam to your pressures and making sure that everything adds up. So a patient who's got a CVP of 15, 16 should be floridly volume overloaded on exam. If they're not, and their CVP is elevated out of proportion to their physical exam, that makes me think twice about how aggressively I want to diurese these patients as well.
Wedge, but a normal index, and is in the lab, and I think a decision tree has to be arrived at. I think in those patients, even in the balloon pump subgroup, in the studies, putting them on a balloon pump for 24 to 48 hours effectively unloads them and temporarily gets us by, allowing them to get to the unit, out of the cath lab to the ICU or to the step down unit without any kind of support, I think ends up leading to that same patient teetering and then going from pre-shock into full shock. So I think that's number one. And number two, Chris, to your question, the pressure volume relationships are not, like, as you know, they're not on a straight line. So small change in volume can incrementally cause a huge increase in pressure, and likewise. So it's an exponential relationship. It depends on where on the Starling curve you are. So yeah, that's the best we have, but even a small change in the end diastolic volume, for example, can cause an exponential increase in your end diastolic pressure, which in turn can significantly impact what we do. So yeah, it's at the very, it's not clearly ideal, but that's the best we have clinically, short of putting in a pressure volume loop and measuring conductance, which we obviously can't do clinically.
So yeah, just like Dr. Prashad, just to echo what Dr. Prashad was saying. So the elevated wedge with a normal cardiac output patient, this is different than the acute AMI pump failure patient. So the pump failure patients is what I was referring to, where a balloon pump will not be enough. The acute AMI shock with an elevated wedge and preserved cardiac output index for afterload reduction, yes, balloon pump will help those patients, but not when you have florid pump failure and a low index coupled with your elevated wedge pressure. Right. Mm-hmm. Yeah. Absolutely. Yep. Absolutely. Yep. All right. Thank you.
Thank you, Dr. Bushara. Our next presenter is Our next presenter is Dr. Ashish Prashad. He is the Director of Interventional Cardiology at Dignity Health, Chandler and Mercy Gilbert campus, the committee chair of the Structural Heart Committee at Chandler Hospital. He is a well-known interventionist here in the Valley, trained a lot of fellows and upcoming attendings. His talks were going to be about large bore access and alternate access. Thank you.
I just wanted to, I'm also an end user and I'm in the trenches a lot, so I think I can give a real world perspective of how things work first in an academic medical center with all its pros and cons, being a close colleague and friend of Ram for many years at Banner, and then now in a very well-functioning community setting here with its pros and cons. So I think it's going to be a fun chat, and let's try to keep it as interactive as possible. As before, I wanted to just address what Dan said, and as far as when he wanted to get the patient involved is the heart failure and mechanical circulatory support team. My only caveat to that is our goal over the next year or two here, because of the sheer volume of cases we deal with, is being that center where we are actually the shock team. And the only reason to send people to places like St. Joe's or Mayo or Banner would be if they need durable mechanical circulatory support and or transplant. And I think this conference is a step in that direction. And I think with the efforts of the people involved, I think the people that will be called will be Dan to come and take care of these patients at our hospital to manage this complex case with the help of an amazing ICU team that Chris represents here and an amazing group of colleagues that we have in the interventional department. And we'll soon have our own heart failure person as well to complement the entire team. So I think we're headed in the right direction, and meetings like this go a long way. So we're going to talk about large bore access. So what is really an essential tool to get safe arterial access? You need to understand the anatomy. You need to have a good three-dimensional assessment of the anatomy. You need to be prepared to plan for any unforeseen obstacles that might come along the way. You need to be able to use angiography to evaluate ambiguous circumstances. And number 4 and number 5 is most important, is to basically be able to escape from complications or even better, even avoid them. So I think these are, the 5 tenets that I use in my mind to guarantee safe arterial access. So just 3 things. I won't delve too much into the anatomy of femoral access, but the 3 clinically relevant pieces of information that are important are this guy here, which is your inferior epigastric artery. That guy is an extremely important piece because you can get a retroperitoneal hematoma, have a perfectly looking groin, and have a patient that's profoundly hypotensive by inadvertently damaging that. So that's number 1. Number 2, these 2 bad boys. The circumflex femoral, either side, medial and lateral, those usually will get injured when you're going up with your wire, when you're either trying to put a closure device in. And the relevance of that is that those bad boys, if not recognized, can't be treated with a covered stent. You need to put a coil in them to solve that problem. And number 3 is inadvertent access in the profunda. And what that leads to is your perclose disaster. And what leads to that is us having to call Seacrest because it can't be managed with percutaneous strategy. Because the profunda, as we all know, and is frequently called the left main of the leg, and provides all these unbelievable collaterals to the circulation below the knee, and jeopardizing that or putting a covered stent to that is not standard of care. So those are the 3 big anatomical, clinically relevant features that we all should be aware of and able to identify on an angiogram. So this is an example of a very high stick in an obese patient. And oftentimes what ends up happening is this gets identified And oftentimes, a decision is made to hold manual pressure. You cannot hold manual pressure on a high stick like this. And you can't even guarantee that you're going to be able to get closure with a collagen device. So the answer here is don't look at this and then say, okay, we're just going to pull the 6-French sheath out. That's not going to work. You need to either definitely use a suture-mediated closure device, but more importantly, get radial access or contralateral femoral access and ensure that at the end of having closed the access in the problem site, you have a completion angiogram that looks nice and there's no leak. Because this, to me, is an often made mistake while we get access. So this is another important consideration of the impact of obesity and displacement of the pannus when we get access. So on the left, you have a caricature of a normal BMI patient where your entry point is relatively at 45 degrees and you're not traversing 8, 10 centimeters of sub-Q. In the mid, you have a guy who's an obese patient, guy or female, who's an obese patient that you have to traverse a large amount of pannus, which if you don't account for when you translocate the pannus, can lead to all kinds of problems, and I'll show you how. And in this last here is a patient whose pannus has been translocated where you now have almost a less than a normal patient distance between the blood vessel and your arterial access point. And if you don't recognize that these changes are occurring, and these I'll show you very nicely on this floor image, you can see how if the pannus is moved up, look where your access point is going to be. You're just riding that femoral head from the bottom of the femoral head to now the very top of the femoral head, potentially in a dangerous retroperitoneal access by just pushing the pannus out of the way when you get access. This is often unrecognized. Similarly, when you do that, you have parallax. And what that does is it completely distorts your frame of reference. Same thing again, you put a needle at the bottom of the femoral head to identify what looks like a reasonable site of the bifurcation. And then you're panning up, and look what it does. It completely changes your correlation of what the anatomy is. And this is all just from the parallax of moving the II. Okay, there are pros and cons of ultrasound. There are a lot of old timers here, and I don't want to belabor this subject of whether it's helpful or not, but I'm just going to tell you two things. The data shows the following. In an obese patient and a patient with peripheral vascular disease, ultrasound is clearly helpful. Whether you want to use it in every case or not, I'm not going to belabor that subject for routine access, but for access related to large bore arteriotomies, whether it relates to putting in a 14 French sheath to put an impella in or doing a transcatheter valve procedure, I think using ultrasound is absolutely mandatory because it allows you to identify a safe zone for access within the common femoral that allows you to stay away from calcium and allows you to safely close the vessel after you're done. Yeah. We're going to go over that too. So I'm not, I mean, I know there are lots of people who think I've been doing ultrasound. I've been doing femoral access for 25 years and the data is sort of nebulous. Yes, the data is not perfect, but here's the more pragmatic approach. In an obese patient, in a patient with peripheral vascular disease, and when you're putting in an impella or you're putting in a large bore, please use ultrasound. Please use ultrasound. That's the least I can ask. So, but however, using ultrasound is not just using ultrasound. You need to know how to use it, right? And that's the challenge. If you don't use ultrasound every time, when you use it in the few times that you want to use it, you don't know how to use it. Because when you are using the ultrasound, you need to first orient yourself in respect to the vessel. And number two, if you use the ultrasound and pay no attention, you're going to inadvertently ride that common femoral and stick high, stick much higher than where you think you are. So inexperience often leads to a high stick when you use ultrasound. You need to be able to see the tip of the needle. The needles, unfortunately, I feel like need some improvement because they're not ultrasonically as visible oftentimes, especially when you poke the skin. And oftentimes what I end up having to do is jiggle the needle to be able to see it with respect to on the ultrasound. And that is often a challenge. I wish there was an improvement, and my recommended simple improvement would be to have a needle tip that was not just fluoroscopically visible, but also visible clearly on ultrasound would make a big difference. We'll come to that too. That's a good point, right? So, and then the last thing is integrating three-dimensional integration of the needle tip versus the ultrasound probe. So this is an example of where you would be with the femoral head. And now if you're a little bit canted with the ultrasound, you again changing the angle of entry. And this is going back to the micropuncture story. So this is an example of some misadventures with the micropuncture, right? The micropuncture is not perfect again. I'm not a big fan of it because this is the kind of stuff that can happen, where you end up taking a picture with just the dilator and you create a retrograde dissection, as you can see on the left side. And sometimes that could happen even when you're taking a picture without a wire up. Most times a retrograde dissection in the femoral is of little to no consequence, but can be an issue when you have to put something through that and may potentially impact perfusion of the leg, especially if you're leaving it in after a large bore procedure. So this is another exhibit, right, where you basically have no wire up and you're taking a sheath angio and you're dissecting an artery. So this happens with the micropuncture, it happens with taking a picture without having a wire up. So my strategy has always been, if you're going to take a groin shot, make sure you have a wire above, so in case there is an issue, you can tack it up with a balloon. So fluoroscopic views of what is now often seen, but never been actually, I never knew what to call it, but the word is imbricated sheath. We see this a lot. It's a big term. What it really is, in a large patient where that sheath, and we've all seen this all the time, and this is the most annoying thing, when that happens, and you know that your wire is not stiff enough, you know that your sheath is kinking, and this is the end result of that, and nothing good comes out of that happening. And we've seen this time and time and time again. So this is an imbricated sheath. And the treatment of this is recognizing this, number one. And number two, stabilizing it with an Amplatz wire and a dilator before you close the device to prevent this. Because this is what's going to happen if you don't recognize what an imbricated sheath looks like. Yeah. Yeah, so I think it's really important to recognize that if you're feeling like your perclose is kinking in the groin, or if you feel like your is not able to, is advanced, you have to not push it, because otherwise you're going to end up with a problem. So micropuncture access, going back to what you were saying, the micropuncture is not for everybody, because these narrow gauge needles, you get less flash on entry. So if you're not used to it, it's a challenge, it's a pain. It has limited wire directability because the wire is kind of a flimsy wire, and Satya even pointed out that you can't even see the needle, which is even more useful, which is another reason to not use it. It's a false sense of security, and it often can track subintimally because the wire is of such poor quality. I think it's great for venous access, for in the IJ, arm access, when you're trying to go higher up, if you're doing some, and also for patients who have small blood vessels, especially if you're going radial. So I think there's some utility with it, but I'm not a big routine user of micropuncture, and I don't think data supports it for all the reasons I just said. And then, of course, you need to always have adjunctive fluoroscopy. So how do you handle vascular tortuosity? This is super important. Transitioning access wire for a wire with greater support, you basically put a woolly up there, you take a 4 French glide, go through all the arterial tortuosity, transition it for, as Satya said, 75 centimeter Amplatz, plus minus pre-dilate, you put a longer sheath under fluoroscopy, because that'll save you a whole bunch of aggravation. This is just routine. We need to do this every time you see some element of tortuosity. Oh, sorry, let me go back one. So this is another example of just simple things, where you, if you haven't seen or if you don't remember, this is, let me go back one more, sorry. Yeah, so this is leakage around a sheath. So this happens a lot, where you go through a plaque and you have a leak that's happening around the sheath. It's a long-term issue. You let it linger for 2.5 hours for your entire procedure, and the right groin now, or the left groin in this case, is massive. So if you see it, it's a very simple solution. Just upsize. If you're putting in an 8, go to a 9. That way the problem is solved and you can safely do your whole procedure without worrying about it. So this is an example, like I was telling you, those annoying superficial, femoral, circumflex, medial, and lateral branches that if you don't recognize can bleed. And the solution is coming up and over, maybe even radial, I guess, and then putting a long sheath into that branch with a microcatheter and throwing some coils in it, because otherwise the patient could have a massive retroperitoneal problem that will remain unrecognized. Vascular closure devices, a brief mention. Again, there's really no difference in the bleeding. There may be a slightly higher risk of infection with use of these devices, may need a little bit more surgery, and especially the collagen-based devices. But clearly, there's a shorter time to hemostasis. We have not noticed, and I have not anecdotally seen, when we send our patients up and pre-closed with an Impella and go up to the ICU, even if it's an alternative access or a femoral access, we leave our sutures at the bedside and are able to pre-close it at the bedside at day 3 and day 5, and have not noticed that it creates any problems in terms of increased risk of groin infection. Yeah. Yeah, so we have a best practice vascular access policy that Dan and I sort of have circulated amongst our structural team for our structural program. But I think in general, I would say, I mean, I think if you have routine use of ultrasound, number one, plus minus micropuncture, left. Depends, right? There are some femoral bifurcations that are high and some that are low. You put an ultrasound, you know where the bifurcation is, you stay above the bifurcation. And you stay above the bifurcation, but mark a spot such that you're not above that infrainguinal point that's concerning, because otherwise you're going to be at a point that is not compressible. So I think the sweet spot is the mid-third of the femoral head in 80% of patients. In 20% of the patients, the bifurcation is either lower or above, and that's where it helps to have ultrasound to guide your strategy. Having said that, having a CT scan for all these other cases, for TAVR and for shock patients, et cetera, makes it even more simpler, because you can look at the CT and evaluate from there. So percutaneous alternative access, so the biggest thing that you need to know about is that the pectoralis minor divides the axillary artery into what's intrathoracic and extrathoracic. And the principle here is you want to stay extrathoracic. And why do you want to stay extrathoracic? Because you don't want to drop a lung, you don't want to have a hemothorax, and you don't want to have a situation where you have to call cardiothoracic surgery to bail yourself out of a complication. Everything to the right of that pectoralis minor muscle, we can take care of percutaneously if there's a complication, either with a covered stent, prolonged balloon inflation, et cetera, et cetera, et cetera. So I think that is extremely important. Two other relevant features are knowing where the brachial plexus is and knowing the relationship of the the axillary artery and the axillary vein. I think if we, and then I'll show you some tips and tricks of how to access the axillary artery, because the angle of entry is a little bit different than it is when you access the femoral. So that's the clinically relevant anatomy from an axillary access perspective. So I'm just going to show you a few things. So how do we screen? These are patients we typically will be able to screen when we do our TAVRs or when we do our shock evaluations. If you have the opportunity, you can screen these patients with either an ultrasound or a CT. Talk about setup of the room, quick mention about access, and then how to get out of axillary access. So you can get a CT scan, you can do ultrasound, you can do an angiogram. Any of this is important, but you need to do some sort of an imaging of the access vessel before you stick it, if it's an alternative access. So if you don't have the luxury of a CT, then this is at the very least mandatory when you bring the patient down to the lab. So take a picture to see the vessel, because the axillary and subclavian vessels, correct me if I'm wrong, Dr. Ashton is here, is often taught amongst the surgeons that it's the most friable and vessel that's most likely to cause trouble in terms of axillary and subclavians as compared to all other blood vessels in the body. Am I right? Yeah. Yeah, exactly. So I think that's kind of what's been taught to the surgeons, and so we should be respectful of that teaching because it holds true when we access it as well. So left-sided versus right-sided, although there's no data, angles are a little bit more trickier on the right side. The brachiocephalic disruption can cause to issues related to providing blood flow to the carotid, and so right hand is often the most dominant in people. So left axillary is usually the way to go. Usually the way to go. So this is germane only to left-sided access, and so it's a bit of an ergonomic challenge if you're not used to doing this. But typically in, say, room 3, where we usually do our work, if the anesthesia is at the head of the table, usually we have echo here, but ideally, and the II and the gantry are on the other side, so that makes it easy. So you're not, usually it's on this side, right? So if you move the II and rotate it back on the other side, we bring the trays for access and all that here. So all your equipment is all here. This is obviously like a tower situation with the Edwards tray, but typically you'll have your situation, your scrub, and everybody else will be here. Your surgeon or your IC is up here, and then your scrub techs are here. And then what you'll really need is, if you have your ECMO equipment, you can either put that here. Our bypass usually circuit sits back here, but may be helpful to have up here. And then that's typically our setup for axillary access. But the most important is having the II eliminated from your left side of the patient and moved to the right side for being able to not being in the way. So this is the only piece of advice for axillary access. Your entry cannot be steep, because if your entry into the blood vessel is steep, when you perclose it, you are going to tear the artery or dissect it. So it's really important to have a very shallow entry point into the axillary artery. And this is the only, if this is the only thing you remember from axillary access, that would be helpful. That'll be tremendously beneficial when you take care of patients. No steep access. It's got to be a very flat, low angle access. And then, so you usually take a picture, you leave an 018 wire. I'll typically leave an 018 wire down the arm. And then I'll take my GR catheter out. I'll leave the wire in place. Yeah. To perfuse. But following axillary implantation of an impella? Yeah. So we'll talk about that, but I'm not a big, you could do that. What he's saying is get access to your left radial and use that as your perfusion sheath and assess for a decrease in perfusion to the arm. But usually the biggest, we'll talk about the biggest inflection point about when that might occur is if this is left in for longer than 3 days. But bottom line is, I think when you're putting it in, I think for the most part, I don't usually get ipsilateral access. I just get femoral access and do it exactly the way I described it here.